Hey everybody, it's Ben, Master Medics, back to you with this week's case study. As a reminder, you can get a free 3-day trial by going to mastermedics.com. All right, so let's get into this case study. You're dispatched to a 74-year-old female with difficulty breathing and an altered mental status. You find your patient sitting in a recliner in a living room of the home. The home smells of dense cigarette smoke. You notice an ashtray sitting beside the patient. The patient presents with pursed lips, some fatigue breathing, and a nearly emaciated build. So very frail, very petite, very small. The patient is conscious and alert, but difficult to arouse and is pretty obtunded. Her skin is pink, cool, and has mild cyanosis to the lips. Her respiratory effort seems to be fatigued. Her blood pressure is 116/74, heart rate of 108. She's 95% on room air, and her blood glucose is normal. With this information and the presentation of the patient, what diagnosis or diagnoses did you come up with in your differential diagnosis? With each of those field diagnoses, what would be your plan of attack? What would be your plan of treatment for this patient? And what do you believe to be the main issue with this patient? Is it ventilation? Is it perfusion? Or is it diffusion? So on the monitor, heart rate's 110, going 108, 110, 95% on room air, blood pressure 116/74. Okay, so let's dive into a little bit of respiratory anatomy for review. So we all inhale through our nose and our mouth, as we should. So the job of inhaling through our nose is air goes through that nasopharynx, goes through these turbinates, and all the moisture in our nose humidifies that air. Whereas we've probably all experienced those times where we have that stuffy nose, and when we try to breathe, we're only breathing through our mouth, and then eventually we start getting a sore throat because we're only breathing in dried air. We're not breathing in the humidified air through our nose. Everything comes down, gets into the lower airway, where it's the job of the diaphragm to go and flatten out, create a system of negative pressure to pull air into that thoracic cavity. Then once the thoracic cavity's pressure exceeds the outside atmospheric pressure, when that diaphragm relaxes in that passive process, the air can escape back out through the bronchioles, lower airway to upper airway. We exhale it out. So we create a negative pressure, increase the pressure inside of our thoracic cavity to greater than the outside pressure. So then that way it's a passive process. Diaphragm relaxes, and the air just goes from a constant area of higher gradients to lower pressure. So the job of that diaphragm is just to relax for exhaling. And then as we narrow down even more, getting into the very end of the bronchioles into the alveoli. So each of these grape-like sac clusters, their job is to get air and diffuse oxygen into the bloodstream at every little itty-bitty level here, and then to take out the waste for us to exhale. But some things can rise. So with COPD, chronic obstructive pulmonary disease, that's broken down into two separate categories. Chronic bronchitis, meaning chronically those bronchioles are inflamed and irritated, and then emphysema, actual destruction of the alveolar membranes. With those chronic bronchitis patients, we routinely refer to them as the blue bloaters, as given by our illustration here. So what's happening in chronic bronchitis is those bronchioles are chronically constricted, irritated, possibly spasming, and with that, it creates air trapping. So with that diaphragm pulling air down in a normal lung, air goes in, it goes out easier. But when those bronchioles are constricted, that reduces the airflow, creates a higher, more turbulence, less reduced flow, essentially more, if you think in the fire service world, more of a friction loss due to having a hard time to push air out through a narrow passage. Okay, so that gas has a hard time escaping the air volume completely to leave through those really tiny orifices. So we have a chronic state of hyperinflated lungs. Now with that, they become those blue bloaters because they can chronically just have a cyanotic appearance. And so they'll be also bloated because the job of our heart is to shove blood to the lungs. Predominantly the right side of the heart shoves blood to the lungs. But that right side of the heart becomes fatigued due to the pressurization in those lungs. Those lungs are hyperinflated. It's harder for that right side of the heart to be shoving blood out against vascular systems that are always being under strain. So with the right side of heart failure, everything kind of backs up with heart failure. So right side of heart failure, they can end up developing pedal edema, distal edema. they end up developing just fluid retention globally. So that's where they're going to become those blue bloaters. And then on to emphysema, the pink puffers. So those pink puffers, what's going on here? So the alveoli normally have those grape-like sac clusters that have a lot of surface area. So every bit of the surface area is for gas exchange to be happening. Blood flows in, picks up the oxygen, jumps off the waste. Lots of areas that is all happening. But with emphysema, there's membrane destruction within that alveoli. So you can see here, all this surface area here is lost for gas exchange and diffusion to be occurring. So that with those destructed and destroyed alveoli, you can see all the surface area compared to this. Not a lot of area for that gas exchange to be occurring. So with a destroyed alveoli, they have a hard time keeping them inflated. And we know that PEEP pressure helps those alveolar sacs stay inflated. So they will do those pink pursed lips, calling them the pink puffers, trying to maintain their own residual PEEP pressure. And with doing that, trying to keep it inflamed, they end up kind of getting a barrel chest too from trying to keep pressure within their lungs. So they'll present with pursed lips, difficulty in breathing, retaining CO2. So your big differences between chronic bronchitis is air trapping, difficulty getting the air in and out, wheezing, excessive mucus production, and then with emphysema, there's just not surface area for that gas exchange to happen, and the patient has an issue with maintaining PEEP pressure. So hard time getting oxygen in, getting waste out. Similar here, hard time getting air out to be able to get fresh air in for gas exchange. So with respiratory failure, we have two types. So respiratory failure essentially begins when that patient is developing hypoxia. So they're not able to use any kind of compensatory mechanisms. It's all failed at this point, and now they're in respiratory failure. So two types. The first type essentially can just be treated with oxygen. So this is a hypoxic patient that is yet to be hypercapnic. So it's just generally an oxygenation problem, or it could be an overall just diffusion problem, or there could be a VQ mismatch. So as we're pertaining to COPD, this isn't as much of an issue as, there could be something here that obstructs with diffusion VQ mismatch, such as like fluid with pulmonary edema in that left-sided heart failure patient. So most generally we're at the point here to where overall oxygenation to all the tissues is the real culprit. In type 2 respiratory failure, this is hypoxia with hypercapnia. So with this, we ultimately just have a reduced tidal volume. There's a fatigue, there's a decrease in the overall respiratory drive, and the diaphragm's not able to pull air in to get to all the areas of the lung for gas exchange to be occurring and appropriate respirations internally. Another culprit is restricted airways. So with asthmatics, chronic bronchitis patients, if it's gotten to this point and the airway is super restricted, this is going to be putting them into type 2 respiratory failure. And then with a decreased surface area can cause this. So with our patient that was presenting, this is a emphysema patient that has that pursed lips, emaciated build, just very sick patient that has destroyed alveoli. So as we described there, this patient appears to be in type 2 respiratory failure because they have a very fatigued breathing due to decreased surface area. So they are at that later stage of respiratory failure when they're not able to just get a breath in because that diaphragm's been working, and ultimately that diaphragm becomes weak. So with that, our treatments are going to be to assist those ventilations with the patients. If that diaphragm's weak, they can't pull in an adequate amount of volume, we're going to assist that in a volume. If it's to the point to where it is a bronchoconstriction issue, that's where the nebulizers and the beta-2 agonists come into play to try to open up those bronchioles to allow better airflow in and out, reduce the air trapping to get better gas exchange so we can exhale more air to inhale more air. And then ultimately going to CPAP and BiPAP, depending on what your services use. CPAP research statistics show that CPAP's a little bit better if it is more of a issue with fluid retention, such as in pulmonary edema, and BiPAP is going to be more better suited for the patient who still needs pressure, but is mostly just hypercapnic, that doesn't need so much continual pressure to assist with clearing of fluids or secretions out of the airway. Okay, but either one, still a lot of mixed research on which one is initial stabilization better, but a lot of research shows that over a period of time, that BiPAP can greatly improve the respiratory conditions quicker than just CPAP alone. So with that type 2 respiratory failure, as I said, they're having, with that respiratory fatigue, having a hard time getting the breath down in. Okay, so in our lungs, there's always a residual volume. This is basically no matter how hard we try, this little bit of air stays at the bottom of the lungs. And if we forcefully exhale, we're only getting to here. Okay, so there's always a residual volume that's down in our lungs, keeping them inflated. So what happens is when that diaphragm becomes fatigued, not able to take a good inhalation volume. So say now we're only essentially being able to inhale air down into here. So we're going to start to develop a little bit of hypercapnia. So as that inhalation or work of breathing gets worse, further into respiratory failure, that air volume getting down into here gets more shallow and more shallow. So then you've got all this tissue down here that could still be getting CO2 into it. Okay, so without getting a good volume down here into the very deepest parts of alveoli, all that body waste, all that CO2 isn't able to get down in here. So if the air is coming down onto here, it's not picking up all this waste from down here. So the body will slowly accumulate more and more and more CO2. And we know that increasing all that CO2 can make the patient very, very, very ill, developing that respiratory acidosis. So we need to ensure that we're trying to get good airflow in to do good gas exchange, good diffusion, and good ventilation to prevent those patients from getting into type 2 respiratory failure. So with these emphysema patients, retaining that CO2, they're at the point they're so fatigued, becoming obtunded, oxygenation, ventilation if need be, and work on that diffusion and overall oxygenation with BiPAP and so on. So thanks everybody for tuning in for this week's case study covering COPD. I'll see you guys on the next one.